Good evening. My name is Dan Welchons. I'm going to be presenting a slideshow tonight as it relates to my first experience using Barrigel and my first experience using Barrigel as an individual that has not done any spacing, an individual that has not really had a lot of experience with transperineal approach. And so we'll go through a case and we'll look at my first day doing Barrigel and just go over some tips that I have to help the new people out there that are looking to utilize this really important product. So I'm Dan Welchons. I'm a urologist from upstate New York. I'm part of a medical practice called Associated Medical Professionals. I'm also part of the medical advisory board for US Urology Partners. We'll be talking about my spacing journey. We'll be talking about my first perirectal procedure, and then we'll go through a series of cases. And these cases are actually the first 7 I've done. They're the first 7 transperineal approaches I've done. And I just want to kind of go through the sort of pictures that we took from that day, go through a video of one of the cases, and then chat about ways to optimize spacing with Barrigel and ways to utilize this product. So like I mentioned, no prior experience with SpaceOAR. I have no previous history of doing transperineal biopsies. I do have a pretty good experience doing transrectal biopsies and doing prostatectomies, both open and robotic. So that helps with the anatomy. Why Barrigel? Well, we had a very good experience with Barrigel at AMP, my practice. We were part of that, the randomized clinical trial that showed how Barrigel leads to less GI toxicity. We found that Barrigel is just really easy to use, and the data speaks for itself as to why it's an important part of our practice now. The workflow that we previously had, because we had a couple partners using SpaceOAR, did not change at all when we started incorporating Barrigel. The only thing that we did find was that the nurses had a much easier time incorporating Barrigel. It was very seamless trying to start doing our Barrigel program. And we also had a partner, Dr. Ruhatina and Dr. Mariatos, that were able to help sort of, proctor new doctors looking to do this procedure, and that really helped. And also, I think with Barrigel, you have to have a team approach with radiation oncologists. It helps to communicate with the radiation oncologist about this, about the spacing. I always try and save the images from the Barrigel procedure so that they can see exactly what was done. And I think also when you're looking to incorporate Barrigel, it helps to coordinate with the radiation oncologist so that you're all on the same page as to how to simulate the patient after the Barrigel has been placed. So we'll start off by looking at this, the first case that I did for Barrigel. I did have a proctor there with me that day, sort of helping, just in case I needed something, but I did do all the cases that day on September 8th, 2022. So we'll start this video. You'll see, September 14th, 2022, that's the date of it. So you'll see the needle coming in here. One of the most important parts about these procedures is making sure that you are monitoring the tip of the needle. That in particular is probably the most important aspect, is watching the tip and the sagittal view as you're going through the transperineal space. You can see I'm advancing it forward, but at every time you can see the tip of the bevel on the ultrasound, and that just makes sure that you don't get into any space that you shouldn't. This black space where you see the laser pointer is the rectal wall, and above that, the white line is the perirectal fat. And so the whole time You really have to be careful to make sure you don't pierce the rectal wall. You have to be careful that you're staying right in that white plane. And when you are in that plane and you get towards the base, you then switch to the axial view, like we're in right now. And you can see the seminal vesicles. And in that axial view, you can see the tip of the needle. And when you see that tip, you can make sure that you're not anywhere near this black space, which is the rectal wall. You can gently sort of move the needle up and down to make sure you're not seeing any attachments to that wall. And then we inject a small amount into that space to sort of start our spacing. And that particular spot is important. You don't want to be too far towards the seminal vesicles where you get underneath. You want to be right at the base. And you also want to make sure that when you inject that there's no resistance. It should be pretty easy, that plane. And you can see as I'm injecting, I'm moving back slowly. I'm trying to keep the needle anterior to the capsule of the prostate so as not to get into the rectal wall. And you just slowly move the needle back, inject the Barrigel as you see fit. You can sculpt it in this manner where if it's not going where you want, you kind of back up and then you reposition the needle into the gel, and then you sort of just maneuver it as needed to make sure that you're getting the adequate amount of spacing. It's not uncommon right here at the mid part of the prostate to see some fibrosis or some scarring. This is often the place where the biopsies have been taken from a transrectal approach. And so it's not uncommon to maybe not get the separation that is seen at the base of the prostate. And that's okay, because then you just switch back to your axial view. You can already see that at the base there's a great space that was made. And then you move backwards towards the apex, you can see the needle. And when you see that tip of the needle, you can kind of decide what you need to do. When you're in that gel, you're safe. And so that's one of the key safety parts of this product, I think, is that if you're in the gel, you know you're safe. And so you can kind of reposition yourself if it's more challenging. You can see I move the needle back, and then if it's not really going, or if I'm feeling some resistance, or I don't really like the position, I slide the needle back into the gel and then move it as needed backwards. You can see the gel is being injected. This is the area where there's a little bit of fibrosis. It's not opening up quite as nicely as it did at the base of the prostate, but it's still opening up. It's just taking a little bit of time to move the needle. I kind of put some downward pressure on the needle from the transperineal space, and that causes the needle to move anteriorly, which can free up some of the fibrosis and help kind of make a space. So as you move upwards and then move backwards, the Barrigel product fills that gap and leads to a really nice result. So there is some maneuvering of the needle. Mostly through this part, the bevel is down. However, if you're worried that things are getting tighter, especially near the rectum, you can sometimes move bevel up and then bring it to the anterior wall of the capsule, and that can sometimes help with the distribution of the Barrigel. You can see here the needle. I'm sliding the probe a little bit to the left and the right to see if we're getting good distribution to the left side and the right side of the prostate in that sagittal view. We then switch back to the axial view to actually check on that and see and make sure that our space is adequate from that position. And I think the key really to this is that there are certain cases that will go pretty quick, and you find the space really well, you start injecting the Barrigel, it opens right up, you move backwards slowly. But there are other cases where you might need to work it a little bit, work the space, you start the space and then kind of move backwards slowly. And in this particular situation, there was some scarring. You can see the base looks good. we move back in the axial view, and there's still a great space there, but as you move towards the apex, you see the prostate's kind of draped around the gel spacer. And so we might try and look to add some gel to the left side or the right side to improve our maximal spacing. Right here, we're kind of right at the apex. I'm moving a needle because I want to try and get the gel to go over to the right side of the prostate or the left side of the prostate. And you can do that quite easily with Barrigel. And kind of the interesting thing about it is that the space stays. So you inject the gel and you get it to the place that you want. And then when you remove the needle, the space is still there, which allows you to kind of make pretty good progress in that you can inject and then move on to another place, and it just opens up. I'm moving it, trying to move the needle over to sort of sculpt the gel over to the other side to try and get that the most amount of space I possibly can. You see there kind of some tissue gave, and you'll see that during the spacing that the tissue will sometimes give, and then you'll notice it fills that void, and then you move on to another spot from that area. One of the really great parts about this particular product, I think also, is that every time you're looking from the axial or sagittal view, you know exactly where the gel is. I can see my needle. I can see where the gel is. I can see exactly where I've been, where I've injected. I feel really good about the position I'm in. There's no feelings of not knowing where the gel is being injected, and that to me provides a lot of comfort in that I know that I'm injecting at the proper position. So here we've got a pretty good space. We feel like, looking at the axial view from the base to the apex, it looks like it's pretty good. And so now we're just measuring. You can see as you get to the apex, it gets a little tighter, and that's usually the case. But for the most part, you can see at the base and the mid, there you got over 1 centimeter of space. And that's going to lead to really significant benefit to the patient when they start the radiation, especially in the cases of ultra hypofractionation. And the radiologist or the radiation oncologist thus far really have said great things about the fact that there's so much space, and they can simulate in a way that they're not concerned about hurting the rectum. And so, like I said, this particular day, there were 7 cases. We did all of those cases in a row. The nursing staff that was with me that day had seen some Barrigel cases, but had never done them herself. And she did great. They were all done under local. We usually for local will provide the patient with some Valium and some pain medications. But all the patients did excellent. And you can see here, after every case, we measure usually from 3 spots in the axial view, and then from the sagittal view, we'll measure at the center from 3 different locations: the base, the mid part of the prostate, and the apex. And for the most part, you will see that the apex is a little bit more challenging. It's a little tighter. We'll go over some strategies to kind of help with that. And not every case is going to be easy. These 7 cases, there were, I think, three of them that were actually pretty smooth. The plane opened up really nicely. The gel went in really easy. And then the other 4, there was some fibrosis, there was some scarring, but luckily I could take my time. I could maneuver the needle as I saw fit within the gel. I could see exactly what space I was creating the entire time. And sometimes it would take 10 minutes and sometimes it would take 15 minutes to place this gel. But in the end, I felt like all of them had really good space, really was going to help them prevent any damage to that rectum when they went through their radiation cases. And so some things to know before you start doing Barrigel, and I sort of refreshed my memory on this before we did our cases. Just the anatomy from the sagittal view and the axial view is important. You can see here is the prostate. You can see there's some neurovascular bundles over here. Those aren't always easy to see, but you usually can see them. The perirectal fat is this white line, and then the rectal wall is right here. From the sagittal view, you can see here's the apex of the prostate. Prostate is here, bladder is here, and the base is here, seminal vesicles off the back. And then you see this rectal wall. This white line is kind of your target, and you're trying to kind of split that line when you're going in with the needle. And this black structure here is actually part of the rectal wall also. One other point that's important, especially when you're doing Barrigel, is to recognize the rectal urethralis muscle, also known as the rectal hump we see here. And there's a hump right where the sphincter complex is, right at the apex. And you want to be careful when you're entering with the needle at that position. So what I found from my personal experience, having no prior history of doing transperineal procedures, not previously doing SpaceOAR, is I felt like after about 5 cases, I was able to do most of it on my own. You're going to find that within those 5, maybe 1 or 2 are pretty easy. Another one of them might be a little challenging, and another one might be a little more challenging as far as fibrosis goes. That's typically the most challenging issue that arises when you're doing the Barrigel. However, there are some other things that you might run into. When you're looking for that target zone, like I said, you have that rectal hump. You can sometimes change probe pressure or lower the legs to help sort of decrease the size of that rectal hump. I've always found that when you when you change the probe to be on the anterior wall of the rectum, you'll see that hump kind of drop down. And interestingly enough, a lot of times also when you're doing a block with lidocaine, and you're looking for the levator muscle, sometimes when you inject that block, you'll also see that you'll get sort of a dropping of the rectal hump just simply by doing the block of the pudendal nerve roots. And when you're confirming the target zone in axial, it's best to wiggle the needle slightly, not too aggressively. You could tear the tissue if you're in the wrong spot. And then you don't really sweep side to side until really you've done some up and down movements. And usually I'm not going to be sweeping side to side until I inject a little bleb of tissue right at the base to make sure we're in the right spot. Notice also that the bevel is snagging some rectal tissue. Whenever you feel like that could be the case, I usually switch back to the sagittal view. And I pull the needle back out, and then I try and find a new plane going inwards, because sometimes it's either the angle that you're going in from the perineum, or sometimes you also can check where the probe is to make sure that it's flat and there's not an angle on the probe, which could be altering your angle going inwards. Then I always switch back to axial and repeat that needle confirmation step. So like I just said, it is important to keep the probe flat and apply just enough anterior pressure so that you get good imaging contact. You will see when you first start doing it that if there's not good contact, you don't get a great image in the gel. If there's air in the rectum, you just can't see much. So keeping that probe flat helps to get a good image and also keep the rectal hump low. And you'll also see that if you are angling the probe downwards, it's going to sort of pinch the space at the apex. And the apex is already a tight spot. And so if that probe is angled in a downward direction, rather than being flat going into the rectum, it can be difficult to actually get gel into that space as you're moving backwards. And so that's a key part that I found in those first 5 cases is watching where the probe is angled and making sure that you're in an adequate position so that you're not pinching that apex too much. And then also, you know, one key when you're seeing that there's if there's not gel that's spreading appropriately is to just find an area that's safe, look at it with the sagittal and axial view, and just inject a couple blebs. And once that bleb is there, you can see whether it opens up easy, whether there's any resistance. And then once you have a bleb there, whether it's an opening that you think is going to be adequate, you can continue to stay in that gel space and then just move back, staying anterior. So again, this is kind of the challenging part I found in those first 7 cases, is that there are some times cases of fibrosis, especially right around the area where the biopsies were taken. And so lowering the probe can help. It's important to use your sense of tactile feel. You know, I sometimes would move the probe up and down and then inject a small bleb. Now, if I felt a lot of resistance, you want to, 1, make sure that you're not in the rectal space. And 2, you want to check to see if maybe that's just where the fibrosis is. Whenever you're finding resistance, it's always best to check the axial view again, check the sagittal view again, see if you need to take the needle out and go in at a different angle. And if you do find that there's fibrosis, I found in those original 7 cases that it was best to go on one side where you feel like there might be more fibrosis and start your actual procedure. Because if you start injecting in the easy spot, maybe the left side of the prostate is not as fibrotic and the right side is. And if you start injecting on the left side, and then when you get to the right side, you'll find that that left side becomes the path of least resistance. And then when you're injecting on the right side of the prostate, the gel is just sliding over to the other side. And that can lead to some asymmetry. However, you can always just take the needle out, reposition it, and then inject on that side. And I think that's one of the interesting parts about Barrigel, is that if you find some asymmetry, you just take the needle out, you change your positioning, and you just sculpt the gel to as you see fit on whatever side of the prostate you find is a little more asymmetric. So some apical coverage tips is that sometimes as you're moving backwards, the needle will cause some artifact, which can make it hard to know where you're going when it comes to the apex. And the apex is very tight too. So as I'm moving backwards towards the apex, I've found that dropping the probe down a little bit, if you can, will help open that space up. And also some gentle pressure upwards in the anterior wall, taking care not to go through the capsule, can be very helpful. And again, as you're going, you have the time to check in the axial position. You can go back to the sagittal position. Throughout this process, you have plenty of time to make sure that the Barrigel is going in the right position. And it's also important to recognize that you don't necessarily have to get 10 millimeters of space, which is what I'm shooting for at the base, and at the mid gland is 10 millimeters at least. But at the apex, you don't want to put too much there, because that actually can be challenging to change the anatomy and potentially cause some issues with maybe the patient's urination. I haven't seen that, but if you get about 7 millimeters of space at the apex, that's perfectly adequate. And so what I found doing these first cases is that Barrigel has an extremely impressive safety profile. Throughout the case, you know exactly where you're injecting. You can see it because it's so hypoechoic on the ultrasound. If it's not going in the right spot, which did happen to me, you can kind of stop, reassess, change the angle and position of your needle, and then start again. The actual setup is quite easy. We do about 8 to 10 in a day. In between, I'm usually seeing patients. The nurses took to this very easily. Essentially, all the nurses need to do is hand you some some lidocaine to numb the patient and do your blocks, and then also hand you the Barrigel syringe. And so after just one case, the nurses were proficient. I would say that doctors can expect that after doing 5 cases, they should feel pretty comfortable, because within those 5 cases, they're going to see some variety of anatomy that might require some altering of the probe, altering of the needle. And I think that the control you have, the ability to sculpt the space, the ability to change what you're doing, the ability to take as much time as you need. Sometimes it just opens right up, but sometimes you can take your time, is a really critical part of Barrigel, and it allows you to get the best possible outcome. There are some questions that have been asked, and this is down below. There should be a chat box, and I'm getting these questions sort of fed to me to answer. So feel free to answer, ask anything that you're interested in. First question here is, it says, as a urologist placing Barrigel, are there any best practices that you can share on how to work with your radiation oncology team? I think this is an important aspect of Barrigel. I have a very close working relationship with our radiation oncologists. Not all practices are like that. We have them on staff. I tend to sort of in the note after the Barrigel actually label how much space I was able to achieve, at least in the mid gland and sometimes at the base as well. And that sort of helps communicate to them what they can expect to see when they're looking at the images, whether the MRI. To be honest, though, most of the radiation oncologists, after they start the simulation process, when they're looking at the MRIs, have no real issues. But every once in a while, I kind of add those to my notes just to communicate with them what's going on. If I see a challenging case, which I have had, where it's been maybe difficulty getting the gel in certain spots, I sometimes leave them a note just to look at this site and see what you think. Another question is, when you started as a new user, how did you get your staff on board and educate them? I kind of mentioned that tonight during the webinar about what it takes. I mean, it's relatively easy and pretty surprising how quickly the nurses sort of picked it up. It's really just handing me a needle for the most part and having some lidocaine up and putting the patient in stirrups. One thing we didn't really show tonight is that typically before I do the Barrigel, I'm usually placing the fiducial markers. Our practice uses those, and I'm placing those fiducial markers. So I do a block and placing the markers. So there's a couple other things that are on the sort of table next to me for Barrigel. But essentially, they hand me the lidocaine to numb the perineum, as I just previously mentioned, and the Barrigel needles as I asked for them. And then they help with the positioning, but it's lithotomy, and all of our nurses are very well versed with that. And another question here, as a new user, how did you prep for Barrigel or scheduling multiple cases in one day? Did it disrupt your clinic? I felt like my first day, I really wanted to stack a bunch of cases on top of each other to kind of just run through the motions, get very comfortable. Like I said, I was a noob when it came to this transperineal approach, and so I wanted to kind of just help strengthen my skills. And so the first day, I do recommend, if you're going to start doing it, is get 5 cases. Put them on there and just go back to back to back to back, and that really can help sort of get the number, get your skills down, the movements with the probe, movements with the needle. And I didn't find it disrupted my clinic at all. I mean, now it's sort of part of our process with scheduling patients. So now once a month, along with a couple of my partners, one day a month, I have 10 of these on my schedule, and I come in and usually it takes a few hours, but it goes great, and it's really smooth. So looks like we don't have any more questions. I'd like to thank everyone for logging in tonight. Really appreciate it. I really have enjoyed using Barrigel. I think it's a really actually fun product. It's kind of like a little bit of a game trying to space the area. And honestly, I find it to be fun. And I know so far now I'm seeing my patients roll through that they really appreciate it and they're doing excellent. So thank you.